So I'm Todd Wagner. I am an associate professor in the department. Spend most of my time in S-SPIRE. And I thought I would give a grand rounds today on risk adjustment and these recurring issues about balancing payment quality and equity. Just to acknowledge, I have no conflicts of interest. This work includes a number of colleagues, some here at Stanford, including Alex and Christine Chi, and then some folks at Boston University, and then some fellows that I've worked with, both Megan and John were fellows here. And I'll go through four areas. One is just sort of some background on the recurring challenges in the US healthcare system and what leads to our desire to use risk adjustment. I'll define risk adjustment, and then spend most of the time talking about conceptual and measurement issues and this ongoing challenge or tension that we have between wanting to create fair payment systems, risk adjusting quality, and then this more recent issue about equity and risk adjustment. So one of the major recurrent themes over the past 30, 40 years is trying to come up with a healthcare financing system that rewards efficiency, but that's also fair. Clearly, physicians and hospitals want to get paid for their work, but we're struggling to find payment systems that reward that in what we think of as socially desirable outcomes. And at the two extremes, we have, capitation, sort of what the Kaiser model is, where it provides incentives for doing too little. And then we also have fee for service, which we all know provides incentives for doing too much. On the right-hand side is just you get a sense of the US healthcare expenditures as a share of the GDP, and that's just from 1960 to 2018, and that comes from the Kaiser Family Foundation in Brookings. The second challenge over this time is obviously the persistent quality gaps that we have in care. And this is the book cover from the 2001 IOM report. Those persistent gaps have continued. And in fact, a whole field of study known as implementation science has developed to work on strategies to reduce these gaps. And then third, this issue of equity. And when we think of equity, often people think of insurance access. And you can see in this Kaiser Family Foundation graph between 2008 and 2019, and then the Affordable Care Act, which came in 2014, clearly changed the number of people with insurance access and improved that. But we still have problems with insurance. And if you were at Holman Day, Kirby Olorda and her colleagues talked about the growth of high deductible health plans. These are health plans where people are expected to pay a higher amount through co-insurance and deductibles, and showed that that was associated with bad outcomes, things like higher rates of strangulated hernia repairs because people are putting off getting appropriate care earlier. So in the past 30 years, we've really struggled to align incentives and come up with ways of improving efficiency, equity, and quality. And we've gone through a number of these well-known efforts: prospective payment, you probably remember many of these, pay for performance, and accountable care organizations. We went through the hospital readmission reduction program and bundled payments, just to highlight. Most of these struggle to sort of enact the effects that we want them to enact. And we can take a simple example of ICU care, which you're probably many familiar with, and we can sort of show the incentives here in ICU care. So we know that from literature that up to about 50% of ICU admissions in the US are not for life-sustaining care. And so arguably they don't belong in the ICU, but paradoxically, even prior to COVID, many hospitals were expanding their number of ICU beds. And you might say, if we have so many patients in the ICU that don't really belong there, why are we expanding ICU beds? And if you look at some of the work out there, including some of the work from Jeff Doppling here in the department, we think of ICUs as treating three different groups of people: those who need life-sustaining care, patients who are dying, and then lower acuity patients, in part where the clinicians just don't trust the ward doctors. And so they want some extra monitoring. It's really, in administrative data, it's very hard to identify these three groups of patients to determine whether you're really just treating those who need life-sustaining care. There can be valid benefits for treating low acuity patients in the ICU, and so you might have a justification for wanting to do so. And then fee for service reinforces all of this. So ICU stays can be incredibly profitable for hospitals and organizations in reimbursement where there's fee for service. But to be honest, if we devote all of our resources to ICUs, what about other care? What about pediatrics? What about improving access to health insurance or education? So at some point we have real resource constraints, and we come back to this question of how do we create healthcare systems that maximize quality, efficiency, and equity. At some point, we have to believe that resources are constrained. And in some sense, we're all paying for this system ourselves, whether it's through our taxes or directly through our premiums. And just to sort of point out our premiums, in 2020, the average individual plan was about $7,000 a year. And if you're paying into a family plan insurance, the average is about $13,700. And those premiums have gone up considerably over the past 10 years too. So you're paying more and more of your salary into health insurance. Now, as we look towards what the federal agencies are doing, like CMS, the Centers for Medicare Services, HRQ, and VA, they're increasingly wanting to use administrative data. We're collecting a lot of administrative data to shape policies and programs. It's sort of, I find it interesting that even FDA nowadays is very interested in this. They used to be the last bastion of randomized controlled trials, but they're getting into this area of low-risk device and wearables where they're trying to use administrative data to inform their policies. But once you use administrative data, these are data that are collected for other programs, billing, tracking. We have to deal with this issue of correlational confounding that happens. And so we want to use risk adjustment to control for sort of the implicit acuity of patients that may differ in different groups. And this happens because we can't randomize people. People are naturally sorting between health plans and providers, and we need risk adjustment to control for this implicit variation. But we also have to recognize that when you do so, risk adjustment creates its own set of incentives. So you might say, as a physician, I'm really interested in treating low acuity patients, what's known as cherry picking. We can create incentives for providing more care over time or upcoding. And then there's this other issue of maybe we'll get in line with specific providers who provide specific types of care to specific patients in selective contracting. And I'll talk a little bit about each of these as we get further along. And I would say over the past 2 years, but in particular over the past year, we're coming back to this question of what about equity in health insurance and social determinants of health? And I'll give a little bit more about that as we get on too. And perhaps the best paper on upcoding is this one by Grusso and Layton, talking about the difference between Medicare and Medicare Advantage. Just to point out that a number of programs use risk adjustment, and you may not know this. One obviously is Medicare Advantage. They use risk adjustment for payments. The Affordable Care Act exchanges use them. And then CMS alternative payment models. We have bundled care payment initiative and the merit-based incentive payment system all use risk adjustment. But also implicitly, Hospital Compare uses risk adjustment. Let me just show you, some people are not familiar with Hospital Compare. If you go to this website, you can start tracking and figuring out where would you want to get care. And if you plug in, for example, Palo Alto, this is the map that you get. And I've sort of selected at this point just acute hospitals. And you can see 3 here that it pulls up, just the top 3. And you get to see this overall star rating. And this star rating has been highly contentious. And then you get patient survey ratings, and you get to see the different hospitals and where they line up. The idea behind this is that it's supposed to create transparency so patients can choose where they get care. Now, we all know that if, depending on your insurance, you may not be have access to Kaiser, or you may not have access to even Stanford. But you can see the different star ratings. You can dig into it further, and you get to see, for example, here are those 3 hospitals. I've just done Stanford, Kaiser, and Sequoia, and you can see the national benchmark for all of these indicators. And I've just sort of picked 4 indicators here that I thought you might be interested in, are all one, they're designed that way. You'll notice high variation, but then note that they all say that these are not better than, or it's better than the national average, no different than the national average, and you get to see how they sort of stack up. And then when there's small sample sizes, you see not available. So there's risk adjustment involved in here, but it's really hard to find the actual methods behind all of the Hospital Compare data, surprisingly so. Implicitly, if you're not familiar with risk adjustment, it's just using algorithms to help us understand the acuity of patients. And I will admit that most of my research focuses on risk adjustment for costs and payments, and I'll specifically talk mostly about that for those of you who are not used to it. But we can also use these models for other outcomes, whether it's mortality or quality. Implicitly, it's a little bit different when we talk about payments. So we're going to have a risk adjustment. It's going to use a regression model to estimate the total cost, sort of the expected cost that we expect this person to have in this year. And it tends to work pretty well across the different metrics. So the real goal when we produce these risk adjustment scores is to produce an average or a central tendency that reflects the average risk of different groups. And this could be a healthy group, it could be a sick group. We want a risk score that's not easily gameable, and then one that's relatively transparent so people can understand it. I should note that different organizations and different people have different priorities on what they see as a priority. So CMS, for example, places a very high priority on one that is not gameable and one that's transparent. Other organizations place less value on things like transparency and more on accurately reflecting the average risk. And for those of you who are interested in sort of the statistics here, most of the scores use averages and they're preferred over the medians. We really want to reflect the extremes. And if you don't reflect the extremes, we know that physicians will work to avoid the extremes or hospitals will work to avoid these extremes. So we want to average, think about the average where you're actually paying for the care at the extremes as well. There are two different foci when we think about risk adjustment. One is a disease-specific risk adjustment. Many of you might be familiar with these. These are computed for a very specific group. So I've given some examples here. For example, the SDS short-term risk calculator, it calculates a patient risk for mortality, morbidities for cardiac surgery. There are many disease-specific risk scores out there. There's also these generic risk scores, and if you're not familiar with them, I'll talk mostly about the hierarchical condition category or HCC risk score that Medicare produces. But there's also the Charlson that is widely used, and Elixhauser, again, widely used. These are typically risk scores that are computed to go across a population. And I will say most of the talk that I'll focus on is going to be on the generics because they're most appropriate when we're addressing questions of value or payment. And as I noted, Medicare, Medicaid, Centers for Medicare and Medicaid Services uses these hierarchical condition categories for risk adjustment. They were created for Medicare Advantage, but they're also used in other avenues across all of Medicare's alternative payment systems. Just to note, they've gone through a number of iterations. The version 21 used ICD-9 codes, then they upgraded it to work with ICD-10 codes. And then most recently in 2020, they implemented version 24, where there was more information on mental health codes. So that's been a huge improvement, actually. All of these risk adjustment models are using diagnostic information that you're coding as clinicians to understand the diagnostic groups that patients fall into. So here's how the structure for the hierarchical condition categories works. You start with the diagnostic codes, it works into diagnostic groups, goes into condition categories, and eventually you create these hierarchies such that you stay in the highest payment hierarchy that you're assigned to. So that ends up with 89 hierarchical condition categories. The way that CMS then does this is they estimate costs or payments, and they put these 89 HCCs into the model. They put age and sex with interactions, and they predict the average risk for this person, and then they calibrate it. The calibration is just the risk score divided by the average spending for Medicare that year. Most recently, that's about $9,300, so that you get to see predicted cost is going to be 1, and then if you have a score, a risk score that's above 1, you're going to have a higher expected cost. Below 1 is a lower expected cost. And CMS produces software that you can pull right off of their website to allow you to enter in your patients and predict what they think your risk score will be. There's 2 timings. You'll notice I didn't put in this regression model, I didn't put T or the timing in there, but you can think about what's the right timing for these distinction between the costs on the left-hand side and the HCCs on the right-hand side. On the prospective risk score, which Medicare Advantage uses, you're using data from this year to predict and estimate what we should pay next year. The concurrent risk score uses data from this year to estimate what we think would be a fair payment or risk score for care this year. So it's a concurrent. I would say that most people are familiar with at least the concept of a prospective risk model. It's what some people see as sort of the purest risk model, although I think that's changed a little bit over the past 6 months, year. You're using data before the surgical intervention to predict the risk of that patient. So if after the surgical intervention the person develops CKD or depression, it's not part of the risk score that goes into that surgical intervention risk score. So if you're interested in paying for the surgical intervention, it would not include CKD and depression. Like I said, it's used for Medicare Advantage, where they're using information from last year to create payments for this year. But the generic prospective risk scores are not typically used in health services research because there's this timing issue that happens. These are typically scores that are based on a calendar year or a fiscal year. And so you can end up with people who are a day or two apart. And so imagine if you're sort of tracking in the data, someone who was enrolled on a study on 12/31/2018, the most recent prospective risk score would be their 2017 data. And if you grab someone the next day, their most recent prospective risk score would be the 2018 data. So you would have a full year of sort of difference in the risk score. And so that creates a challenge when people are using this for health services research. So that's led people to want to use a concurrent risk score. And just to highlight, the concurrent risk score is based on information from the whole year. It ignores the temporal sequencing. So some people have just sort of said this is wrong from the get-go. You would have a risk score that looks at the entire year, irrespective of when you develop CKD or when you develop depression. It would all be part of that risk score for how you think about surgical interventions. So I think for a long time, people sort of had an implicit preference for the concurrent risk score. I just sort of want to walk through ways that can break down. So here's sort of what I talked about as sort of the purest model methodologically, and you would implicitly know all information about the patients prior to the surgical intervention and the CKD diagnosis and the depression diagnosis. But let's just say you have imperfect information. One way that might happen, for example, is if a person in your cohort changed jobs and now they weren't in one data set and now they're in the other data set. And so you can imagine perhaps they had depression diagnosis beforehand, you just didn't observe it. And so in this case, you see it after, but it really was beforehand. And this happens all the time because there's cycling through of insurance, and it's very hard to see perfect information on the insurance information. The other one that we're thinking about more recently is this idea of sort of structural barriers to care. So in this case, we'd have something like CKD diagnosis and depression diagnosis. Maybe the person has struggled to access care for a variety of reasons. They've had these things, but the diagnosis in the data just comes after the surgical intervention. And so implicitly, you could think whether it's structural racism, structural access to care, ways that could, those underlying conditions were actually manifest prior to the surgery, but showed up in the diagnostic codes afterwards. And so I think people are starting to recognize that the data we have don't really allow us to perfectly identify the timing of these things. Implicitly, there can be some latent timing as well. So I think over time, people have been more comfortable with concurrent risk scores. Just to note that these models are all imperfect. There's a great paper by Tom McGuire, found the imbalance of the extremes in the US. They also looked at some other countries, but in the US in 2017, 1 in 1,000 enrollees were underpaid by $190,000, and 1 in 1,000 enrollees were overpaid by $95,000. So if you're a private physician curious about how you're going to get paid, you have to pay a lot of attention to risk, because obviously you don't want to be underpaid by a huge amount that would be catastrophic for your sort of success of your system, and trying to manage what's happening at the extremes is really important. These are rare events, but like I said, being underpaid is incredibly important, and it's more likely than being overpaid. So as physicians, we see physicians, hospitals, insurers doing a lot to try to manage their risk. Obviously, there's risk pooling, there's sort of forming bigger organizations so that you as an individual take less risk. There's selective contracting. We see that more and more, where you're working with specific insurers, specific providers to make sure that your patients in that risk is what you're expecting to be, whether it's a quality or a risk issue. And then we're starting to see it even at the sort of local discussions. Do you want to accept this patient? Is this patient a good risk for you as a physician? Do we want to accept transfers? Is that a good risk for the organization? I would encourage all physicians to say that they should care about risk adjustment, whether it's about their own payments. Each time we think about risk adjustment, we should think about sort of the gamble implicit in getting that $190,000 underpayment or the overpayment. So investing in risk adjustment is in part important for us to think about how do we reduce our gamble. We should think about, are we over-relying on diagnostic codes? So I'll show you some research that we've been doing on sort of pharmacy data. You can use other data to pull in here to get a better sense on what's happening at the extremes. I would say there's been an over-reliance on very simple statistical models that are transparent but are less robust. So we should think about more sophisticated statistical models. And then finally, we'll come back to this question of gaming. Are we creating incentives for gaming? That's always going to come back. And so there's always this challenge about, should we include these things, these variables in our regression or not, because they could create gaming. I would say over the past 20 years, this has been a very sexy area for people to work in, trying to figure out the model and the model fit, because we realize these are imperfect and we've spent a lot of time trying to figure out, can we make them better? I've worked in some of this area myself. I'll give you an example of it, where we can pull in information on pharmacy. We understand that functioning data is not typically used for the risk scores, and we could say we could improve on our risk scores if we were including functioning data. There's many gauges of success. I think every researcher has their sort of preferred metrics. We often report R-squared. My preference is these calibration curves or the Hosmer-Lemeshow deciles. I really want to know what's happening at the sort of the top decile of expected cost and the lowest decile of expected cost. Can we improve on those misfits, what Tom McGuire showed with the $190,000 underpayment and the $95,000 overpayment? So, everybody sort of focuses on the measurement issues, and those things have taken center stage. And the conceptual issues are, what variables are in the regression model? What are we trying to predict? Have often been downplayed. And I think those have been coming back to the fore, so I'll highlight that in some of the research that we get into as well. So one of the projects that we worked on for VA, so in 2015, VA was spending a fair amount of money for commercial software. It's this DXCG software. This is the same group that creates and inspired the HCC software. So VA was spending about $200,000 a year to use this risk adjustment software to create risk scores for its own tracking of its systems. And they asked us to think about, could we create a similar risk score based on whether it's the HCCs or some free data that are out there, because VA has a lot of administrative data that would save it from having to have this commercial contract each year. So I would say initially we really struggled to match the DHCGs. We compared the V21 risk score at the time to the DHCGs, and you can see that although those R-squares aren't huge, they really matter at the extremes. We're talking about big differences in sort of that gamble at the extremes. We did this for 6 subgroups. This was a general population, just a random sample. We took older folks. We took folks with mental health substance use diagnoses, which is a large group in VA. The more specific you get into these groups, the worse you tend to predict them. So for example, for the high cost group, which is much more transient, we don't typically predict it that well. And as you might expect for the low risk group, these are people who don't use a lot of care, they're relatively healthy. We don't predict them that well either. I would say we succeeded in the end with 3 changes. One is we started using pharmacy data. And there's a lot of information that you can pull out of our pharmacy data that help you predict what's going on at the extreme. So if you take a very healthy sample, for example, you can see that some of them have specific types of pharmacy utilization that might help you predict what's going on and why they aren't using a lot of care. So maybe they're on an antihypertensive, a high cholesterol medication, and you can use that drug information to predict what's going to happen for that year or the next year. In particular, at the time, the CMS HCC version 21 only had 4 mental health and substance use groups. And we worked and said, that's probably inappropriate for VA, which has a much higher prevalence of mental health issues. And so we worked to update this psych CMS grouper, and it created 62 groups. That differentiates, for example, things like PTSD, which is much more prevalent in VA, and that helped us improve our model fit. And then we just use more statistically sophisticated models. So CMS uses a linear regression model. They place a lot of value on transparency. And we ended up using a square root transform model that helped us sort of exploit the extremes. So that was a successful project. And the risk score that we produced, known as GNOSIS, which is Greek for chronic condition, is now rolled out quarterly to all VA enrollees for the entire VA. We did some follow-up studies. So John Lin, who was a fellow here at Stanford, was really interested in this question of what happens when you track people. We only typically use 1 year of data for our risk scores. What if we use more years of data? Can we improve on that? We thought maybe at the extremes, we'd give more information about whether it's the time you've been with something like diabetes or chronic kidney disease. Surprisingly, we were really shocked that the answer was no, that we couldn't improve on the model fit with more years of data. So adding 2 or 3 years of clinical information provided almost no additional diagnostic leverage. And that was published in Medical Care in 2020. The other one that we started looking at, this is the famous New Yorker, now 10 years old. It's hard to believe, this question of, can you predict high risk, high cost patients? So keep in mind that about 5% of patients are responsible for 50% of spending. And we found that you can't easily predict high cost patients. We did a study, Jean Yoon did a study, a colleague of mine, and that the highest 10% of costs at baseline, they just don't stay high cost year in, year out. One of the reasons is mortality is very high in this group. So it's very hard to predict high cost patients year in, year out. The sort of the group that we found that was the most stable, at least in VA data, was the spinal cord injury. But for many commercial insurers, that group is not always in there. They're sort of moving typically into Medicare or Medicaid, depending on the disability. Another follow-up study that we worked on is how fair is this risk score for safety net providers? We took the VA as a safety net, and we examined the version 21 of the VA. Keep in mind, this was back when version 21 only had 4 mental health and substance use HCCs. We examined this across a large number of patients, and our estimate was that they way underestimated sort of the mental health burden in VA. The version 21 identified 690,000 patients who had a mental health substance use problem. When we created this psych CMS risk score, we identified almost double had a risk, had a mental health substance use problem. The things that the version 21 was missing was depression not otherwise specified, PTSD, anxiety. And so we estimate that the average cost of care underestimated considerably for this version 21, underestimated considerably for safety net providers. And it's very interesting now, the version 24 for HCCs includes a lot more mental health substance use conditions. So it's really easy to get sucked into the measurement issues and think about, are we measuring the models with the right variables? What's happened over the past year, it's undeniable that the conceptual issues, especially issues of equity, and equity not being just insurance, are coming back to the fore. So what people are sort of asking ourselves, what variables are we missing from our own risk adjustment algorithms? And should we be controlling for those factors? We know implicitly that all algorithms include age and sex. What about these social determinants of health? Should we include information that comes from patients about whether they're homeless, about whether they have access to good education? So those questions are starting to come back and being of interest to people. So in many regards, this is work that I've done with folks here at VA, including Alex in the department. We see that the VA is purchasing more care. It's forbidden from using selective contracting. So you could right off the bat see we were interested in understanding, should VA be concerned about this? And this is that NOSIS risk score that I helped create. We see that when VA is providing care to veterans in the VA, the risk score is much higher, about twice as high. And this is done for two groups. The first one is the total knee arthroplasty, then when it's providing knee replacements in the community and paying for those. So you get to see this risk score is about 3 for veterans providing TKAs in VA, and 1.5 if they're getting it in the community. Cataracts, it's higher in the VA than again in the community. The magnitude of the difference isn't quite as high, but again, it's a concern. And we've having these discussions about how should VA use this information for selective contracting. It raises this question of, is the playing field truly level? This is a New Yorker cartoon from the 50s. I think it's still very adequate. We build these homes based on data that we have, these administrative data, and yet we have to think about, are we creating something that's really equitable, especially across vulnerable populations? Obviously, this question of equity, structural racism, social determinants of health that come to the fore. There are 2 papers that I'll point you to. One is by Mark Shepard that basically says when we set up risk adjustment, what we're seeing is that some selective contracting is happening with providers where they're avoiding hospitals that provide care to patients who are more vulnerable because the expected margin on those patients is smaller. So implicitly, selective contracting is a major challenge. And then just more recently in health affairs, David Lorenz and his folks talk about this thinking about social determinants of health and social risk factors in health and risk adjustment. So I would encourage people to think about those issues. And are we building a truly level playing field with risk adjustment? I don't know that there's ever going to be a complete answer, but perhaps having the discussions will get us part of the way there. So here's, when we talk about social determinants of health, here are the issues that we're talking about. One is access to education and the quality of that education. These are often things that are very outside of health. So on the upper right, you get to see this sort of health quadrant, but now we're starting to think about other ways that flow into it. That would be the neighborhood and the built environment in which people live. Do they have access to healthy food, for example? What's the social and community context? And this is the Healthy People 2030 vision of social determinants of health, and thinking about, should we include variables from sort of educational models in our risk adjustment models? Should we include questions about our variables from economic stability in our risk adjustment models? It raises a series of interesting and sort of conceptually complicated questions. So I had given this as a sort of a framework going back, and we can think about including many of these variables if we believe sort of this bottoms risk model, that we're, because of our imperfect information and structural barriers, we want to include as many of these variables as we want to get a better risk score, a true implicit risk score for the patient. Housing is one that I like as an example that I think also highlights the challenges that we face here. So there's a considerable literature that shows that people who are homeless or having housing instability have poor health. And you can imagine a whole host of reasons why that would be true. One would be higher prevalence of mental health problems, higher prevalence of health behaviors that you might not see, for example, on the diagnostic codes. Things like smoking, cigarette smoking is not well coded in diagnostic codes. And so issues of housing might be picking that up. But it could also just be that there's issues about, really it's hard to get access when you're having issues of housing, logistical challenges. How do you get to the hospital? How does your transportation unfold every day? Might be a little bit different. And then if you're a person with housing instability, thinking about how are you going to get your medication renewed? Obviously, mail order doesn't typically work in that situation. How do you communicate with providers to know whether you need to get follow-up care? Many of these folks have cell phones, but that's also a challenge, especially if you're moving and trying to figure out issues of transportation and then the timely follow-up. So there's been a lot of interest in trying to think about, how do we want to build, or should we build housing variables into risk adjustment. But there's also competing demands. So one, can you measure these risk factors accurately and precisely? So I would argue that homelessness is really hard to measure. It changes, there's stigma associated with it. So it's really hard to measure, at least in administrative data. So you'd have to think about ways of building that in to the administrative data. We've done some of this work trying to figure out in administrative data that have zip codes of the housing, sort of people moving a lot with the last 3 digits of your zip code. Now that you could just be identifying residents who are moving a lot as they change their residency, or you might be identifying people who are sort of bouncing in and out of homelessness. There's also, you have to raise this question of, are we inducing some sort of coding or gaming? I have a harder time thinking about if I include risk factors for homelessness, that I would sort of install a gaming. It's harder for me to imagine that. The pharmacy issues that we talked about earlier perhaps could, especially if it's a huge bump in the risk score. You might induce some physicians to think about, how would I prescribe to my patients so that I get higher payments or risk scores in the future? So pharmacy might lead to gaming, but I have a harder time thinking that, for example, housing will lead to implicit gaming. If the risk score is used for financing, it raises really challenging questions. So imagine a lot of these risk scores are coming from CMS, where they're using them for payment for Medicare Advantage. We really don't want to finance housing through healthcare. It's just too expensive. Housing is much less regulated than healthcare, and the salaries of professionals in the housing industry is lower than the salaries for professionals, for surgeons, for example. So we really don't want a surgeon working to find housing stability for their patients. So in some sense, we have to be very careful about how we set up risk adjustment, especially if it's being used for payment, that we're going to end up financing social determinants of health through the healthcare system, where it really needs to be sort of coordinated outside of the healthcare system. And so implicitly, there's been this growing concern that as we push more value-based payments, we're going to create this wrong pockets problem, that we're going to create artificial challenges between different divisions of societies, between housing, healthcare, criminal justice, and what they think of as this wrong pockets problem. One question is, how do we bring those back together? That's been a huge challenging point. There are instances of innovations across the country where groups are trying to think about, how do we coordinate services and track those services so that if we're giving someone access to food or housing, that we can then understand how it affects healthcare, so that we can make a better, stronger case for providing those services. So this is a diagram that for a grant we just submitted last week. So there is a group in New York known as Healthy Alliance. They are a trusted broker. They are trying to work across healthcare, public health, and social services to try to fix this wrong pockets problem. The specific question that we're addressing in the grant is, if we work, does Healthy Alliance improve access to these social determinants of health? Does it have a savings for healthcare? So to try to figure out, is implicitly, are there spillover effects that would help healthcare, such that the groups can come back together and say, there's actually a desire to keep this going because it helps us. So one of the challenges that you'll see is that governance is forever a challenge. If it's just healthcare, or if it's just the sector that's paying for these things, often they'll disinvest in the service because it doesn't benefit them, it benefits somebody else. So a number of years ago, Keith Humphreys here at Stanford and myself were looking at why VA was disinvesting from substance use. And it was because it didn't have a return for the hospital itself. The return was for criminal justice, but we couldn't get the VA to work with the criminal justice program to say, how do we share in this sort of trusted broker alliance to sort of fix the financing problem? So VA was getting out of the business of providing substance use, and that was driving up costs in criminal justice. So again, this was a grant we just submitted to RWJ Foundation last week, trying to understand sort of this innovative model for Healthy Alliance, and understand how do we improve the connections between social determinants of health and health outcomes. So that's sort of my highlight. I think these issues on risk adjustment, social equity are going to be here for the next 10 years, trying to balance these challenges of gaming, transparency, and sort of accuracy in the models. The balancing between the measurement and the conceptual issues is forever going to be a problem.